Okay, perfect. Well, thank you so much for everyone's patience. One thing we can never prepare for is technology. So I appreciate you all for joining this morning, as well as, again, just your patience. My name is Tori Hildreth. I am a social worker on the palliative care team for Corewell Health, West Michigan. And today we'll be doing a discussion on an interdisciplinary discussion surrounding the impacts of health equity. And with me this morning, I will have Molly Dollahan, one of my lovely colleagues, as well as Natasha Hennessy. And so we will all be talking to you about health equity, which is work that we do every day, things that we see in our patient situations and our patient care. And the takeaway today we want is for you to be able to name health equity, as well as knowing what is happening in our community right here in our own backyard, and how is it impacting the patients that we serve. We know there is a large ripple effect when there are inequities, and our goal and our takeaway today is to equip you with the tools necessary to continue to do this hard work efficiently while making sure we're being mindful of others. So let's dive right into what is health equity. Think of equity as an absence of unfair and avoidable differences among groups of people. This is one of my favorite diagrams because it can clearly break down what a lot of people would think we should have equality for all. Well, equality, as you can see, is equipping everyone with the exact same tools and resources. And we don't want that. We want a little bit more. We want equity, which is customizing tools and identifying what individuals need based on their social determinants of health and the things that have impacted their lives. Health equity can really only be achieved when everyone can obtain their full potential of health and well-being. Also, health is such a fundamental right, and everyone is deserving of such care. And so take a moment to look at this diagram and to know how the differences of each of these can impact our patients and why our focus is equity in itself. So now let's shift to health equity data. And how is this captured? How do we know we need to do better in our community? Well, the CDC and the World Health Organization, among other public health sectors, have started to actually prioritize health equity data following COVID-19. They have intentionally found these 6 categories to help improve quality data. So we have race and ethnicity, preferred language and sexual orientation, gender identity, and disability status. These, over the years, have been generally underreported. We also suspect that they're still underreported because there's a lack of standard to collect this information. There's also been limiting factors at many standard healthcare operations, not having the staff or the team to be able to create metrics and to be able to measure these things in our own community. If we have better collection of data, this is eventually going to help identify areas of improvement, as well as reduce these health disparities in our own community. So let's talk about social equity. Social equity is impartiality, fairness, and justice for all people in social policy. It considers the systemic inequities to ensure that everyone in a community has access to the exact same opportunities. It acknowledges that inequity still exists and it works to eliminate them. And this graph is highlighting the 7 main drivers and interventions that promote social equity. We have culture and understanding community, legal compliance, and equipping staff and stakeholders, as well as creating equity champions, diversity and inclusion, and ultimately practice. If you think of culture, think of focusing on our equity champions, admitting and being honest about our past inequities, while we also focus on building integrity and trust in an open dialogue. We should be able to talk about equity with our colleagues, with our teammates, and with our patients. Then when we think about understanding the community, we think about what are our community demographics? What are their vulnerabilities, and how does that impact, or how does that limit them to the care that they deserve? While we focus on the diversity and inclusion, so having honest and open, inclusive conversations, having fair personnel practices, and planning and promoting equity within our administration, our service level, as well as being accountable with one another. And lastly, practice, which I think is one of the most important. We can learn more information, we can champion, but how are we practicing this every day? It's reducing barriers to employees, making things equitable, making decisions equitable, and then rewarding those decisions. So many of you have probably heard of determinants of equity. It is something where we are focusing on the people that live, work, and play in their area. All of those conditions factor into determinants of equity. I really like this tree because I picture this tree as a patient you're consulted on. Look at the layers and the roots that impact their care. If that patient might have been late for your appointment, pause and reflect on maybe why. Did they have access to safe and efficient transportation? Did they have barriers to getting here? Or do they speak another language and it's hard enough to simply navigate the world? Thinking and being mindful of how these shape and impact our patients is very important, and it should be work we're already doing. Equal opportunity in these areas is very necessary for people to thrive. And that's what we want our community to do, to thrive and reach its full potential, regardless of race, income, or language spoken. And this is a quick snapshot of social determinants of health, or SDOH. You may see that this has also been really pushed and rolled out following COVID-19 from the Department of Health and Human Services, as well as the CDC. And this wheel is really highlighting the different impacts: safe housing and transportation, food insecurities and discrimination, as well as health literacy, and so many more. Think of this: the more we spend time with our patients, the more we are able to engage and understand their barriers as we do our goals of care conversations, or even as we're simply talking to them about the symptoms that impact their life. We need to prepare to support them as they face the world, the disadvantages that they face, and the inequities that are a part of the system every day. So this analysis here is by the American Community Survey, KFF, which is highlighting health disparities driven by not only social, but also economic inequities, excuse me. There are 6 categories here, and there are so many more that can be highlighted: economic stability, neighborhood and physical environment, education and food, community safety and social context, as well as healthcare. This refers to avoidable differences in health between different groups of people. And these widespread differences are the result of unfair systems that are negatively affecting people's lives. This doesn't just happen in our own community or here in Michigan or even here in the United States. This is a global scale. It affects all countries. People born in areas where poverty is high might have reduced access to safe housing or clean water, healthy food, or education. All of this is impacting their health. On this chart, you can also see how racism and discrimination is impacting all of these, resulting in changing everyone's health and well-being, impacting mortality, life expectancy, and health status. Functional limitations can be noted as well. It creates such a divide. Changes in our government policy are truly necessary to even begin to overcome this. So let's focus on structural inequities. This describes disparities in health, in wealth, resources, and other outcomes that result from discriminatory practices such as legal or educational, business, government, or healthcare systems. It's ultimately resulting in a power imbalance when one group has historically made the rules that intentionally or unintentionally exclude others. And we think that there are so many structural inequalities, but there are 6 major forms that the CDC has identified: education, housing and healthcare, race, gender, and media. And some examples of structural inequities, such as education, would be students in low-income neighborhoods that are receiving inferior education compared to those in wealthier areas. Or you think of housing showcases maybe systematic segregation through zoning. And zoning would be things like green space and large lots that are in wealthier neighborhoods, but also then not creating that same ability for those in low-income areas. Race, for example, there is still a very large racial housing gap that still exists. Poor neighborhoods are less safe. Schools are even of lower quality than they are in affluent areas. And then one of the last major structural changes we see here is gender. So gender biases are still existing in the workplace every day. Women versus men in the workplace, leadership roles, roles given, levels of responsibility, and there are still income disparities. So why is it important to address disparities? Why is it important to take the time to know these layers that impact our patients? Well, because addressing these disparities is not only incredibly important, but it's improving our nation's overall health and economic prosperity. It's going to be increasingly important for us to name and talk about these disparities with our patients, because the CDC projects that in the next 50 years that people of color will account over half of the population, and the largest population will be among those of the Hispanic or Latino population, as well as Asian. So if we take our part every day to learn more about our patients, we will be able to provide better care and send them back to the community, and it will have such a positive ripple effect if we all can continue to do intentional work. So I wanted to take a moment to really bring to the forefront something that's happening here in our backyard. And Molly thankfully brought this to my attention. Our Kent County, right here in our own backyard, has created a community health needs assessment. Not only did they create and launch the data from last year, but they have also been doing this wonderful assessment since 2011. So long time now. And it's aiming to identify, understand, and prioritize the needs of our residents here. And this was conducted through the Kent County Health Department, as well as local health systems and over 60 community-based organizations. It's a 164-page document, and I have only the ability to capture a few slides here and 4 topics that have emerged as priorities from the data that was collected. Data such as surveys, focus groups, phone interviews, and even community sessions where people have sat down to talk through these things. And these 4 topics that emerged were housing, healthcare, access to medical care, and access to healthy foods. Now, these 4 slides are just relevant to these priority topics. Imagine what this 164-page document can hold and show of our community. And since the first assessment in 2011, Kent County has used this MAP project here. And you'll see this diagram, which is a continuous loop of MAP standing for mobilizing for action through planning and partnerships to guide the process. So step 1, we are building our community health improvement foundation. We're then telling the community story, capturing their quotes in surveys, capturing things and the difficulties that our patients face in different assessments, as well as looking at what's available to patients and to their families in the community currently, or what needs to be changed or added. Taking from phase 2 to phase 3, continuously improving the community. So this loop doesn't happen just once. It is continuous as our Kent County Department and as many other counties continue to learn what impacts their residents. The Kent County Health Equity Council is continuously planning to meet. Ever since COVID-19, they have continuously met regularly with the Hispanic Centers of West Michigan, as well as the Grand Rapids African American Health Institute. So we're going to dive into one of those 4 priorities, housing. These are the housing community identified issues pulled immediately from the patients in the community that completed the survey. People who rent their home are disproportionately impacted. I found it extremely disheartening to see that from 2017 to 2022, housing increased 15% for those that owned homes, whereas the housing cost for renters had increased by 36%. Talk about inaffordable. These increasing costs and gentrification is causing our residents and patients to be priced out of neighborhoods. People are flipping properties or selling them at a higher rate. I'm sure we have all seen this happen in the community, or we've heard patients that are impacted by it. A lot of our patients also have housing instability. So more than 7,000 people have applied for the Section 8 housing during the 5-day window. That is a lot of different people. And Grand Rapids and Wyoming can have a wait list of up to 5 years before being contacted. I know firsthand the patients that are worried that they won't find stable housing before something happens or they become homeless. So then thinking of homelessness, that has also increased 70% since throughout 2019 to 2023, and Black residents are disproportionately impacted. A few potential solutions were identified that the CHNA is working on implementing. So expanding current eviction prevention services, helping residents access better care and better services, making sure that the local housing policies are up to date, protecting renters, reducing housing costs, and then addressing other barriers to home ownership. This data chart on the right was pulled immediately from the survey as well, which is highlighting how Black and Hispanic and Latino adults are struggling to pay for housing expenses, where slightly fewer white adults are reporting being unable to pay for housing. This data is showing such a gap in 3 years, and the gap is continuing to increase. So with this data here, imagine what it could look like in just 2 years' time. Next, we'll dive into the next point of health insurance. So health insurance impacts access to all. So their data points here are not just health, also dental, medical, mental health, as well as prescriptions and medications. And these are the 3 bullet points that they've struggled with: navigating health insurances, lack of insurance, or being underinsured. Many people have trouble signing up for health insurance. I have been doing this for 6 years, and I am still learning things about how to help patients apply and how to navigate the insurance system. Not having someone that can sit down with them maybe to talk through these things is also causing a lot of confusion. Patients might not know if they have coverage or who accepts their insurance, or understanding the cost that they have to pay out. Deductibles can be high and some services aren't covered. Now, a lack of health insurance is also a barrier. Not having access to employee-sponsored private insurance, or not being able to afford that insurance through their employer. Income might be too high for Medicaid, but then their income is too low for the marketplace. We know many people who are stuck in this large gap. And then undocumented immigrants are ineligible for any federal funding, including Medicaid and marketplace coverage. They oftentimes have something called ESO, which is an emergency level services, but also not everyone can receive that. There's lack of care options, and a lot of people do not accept public insurance. It takes a lot to read through this PowerPoint, to read through the 164 pages of data, and this is only captured in our county. So imagining what our state is doing, imagine what our nation and what the world is impacted by these concerns. So thinking of, again, potential solutions over this next year, providers may be starting to accept public health insurance, expanding low-cost options, providing education, and even resources to different health insurances. So making sure that patients and their families know their current benefits and cost of care. Compared to adults, one of the data points was stating that even with private insurance, those who were uninsured in the past year were 5 times more likely not to seek needed care for cost. Those with Medicaid were nearly 3 times more than those with private insurance. And that quote is just highlighting that even those with insurance, there is still a gap to wanting to receive care because of the price and the cost that will come. Our third top priority is access to medical care. So there's a high cost of medical care, which is a huge challenge. Cost was a barrier for 10% of survey respondents for our health insurance over the whole year, and 40% were uninsured at some point in the past year. Proximity is also a difficulty. A lot of our patients live in rural areas. Is there public transportation? Do they have access to get from those rural communities into the city? Many new Americans, like refugees, asylum seekers, and immigrants, have different environments. They have to balance and navigate these new systems while trying to also have language barriers that are compounding these challenges. They rely on technology for navigation at different insurances or through different appointments, knowing that that itself is creating barriers. A lot of patients might not have insurance, so they might not have a smartphone. They might not know how to utilize a cell phone or any technology for these health appointments. And then negative interactions. People of color and the LGBTQIA adults reported experiencing discrimination right here in Kent County. Adults were more likely groups to be reported as dissatisfied with the health insurance. 1 in 3 Black residents and 1 in 6 Hispanic Latino residents said that they were treated worse than people of other races when receiving health care in the past year. Potential solutions over the next year that the CHNA will start looking into will be mobile health units. I know this has been very helpful for a few different communities that this has already helped as far as mobile MRI stations, mobile breast clinics, dental care, expanding and improving transportation options, making sure that we have more medical interpreters or bilingual staff, having a health navigator sit down one-on-one to assist the families with these complex and unique situations, while ongoing cultural and sensitivity training for providers, care, and staff. According to the data captured, 1 in 4 surveys respondents faced barriers when trying to access healthcare in the past year. And many of these were refugees, immigrants, and the LGBTQIA adults. And our last top priority is access to healthy food. So the 2 bullet points here are dietary patterns and food choices that are largely based on proximity and cost, as well as gaps in food assistance. So some communities have poor food environments with easy access to food that is less nutritious, maybe higher processed, or they have limited access to fresh or whole food choices. You'll also notice that there tends to be a higher amount of fast food and higher processed foods in low income areas, whereas in more affluent areas, there are higher whole foods. There are different types of markets that are high cost, just showing you the gaps in care of our community. Many of the residents are reporting compromising nutrition, purchasing less healthy foods because of the price. The price alone will send a patient home that might be on a sodium diet or might need to be mindful of their intake. Well, if they cannot afford that, that will be such a barrier as they try to continue to improve their blood pressure or as they continue getting worked up for a transplant. It's a gap. And transportation is such a barrier as well. Many people don't have the ability to afford a personal vehicle. So not having access to public transit, not being able to get to it safely, or not being able to know how to navigate this because they're of a different culture and they do not know English. Gaps in food. So income limits for food assistance are huge for a lot of people. There are a lot of patients who might not necessarily qualify for food assistance because they make too much money, but yet they don't make enough money to bring healthy food home. A lot of the food pantries also are lacking healthy food options and culturally appropriate food for families. Some potential solutions are mobile food pantries or mobile farmers markets. I know that the Feeding America has started to initiate that in our community as well as in the rural areas north. Increasing the availability of fresh fruits, cultural appropriate food items in food pantries, expanding food assistance programs who don't currently qualify, but still facing this insecurity, and nutrition education, as well as getting into our school system to start our children in knowing how to eat healthy and how to maintain that on a budget as well. According to the data, 1 in 3 people face food insecurity in Kent County. It's up to us to make sure that we are supporting our lawmakers, we're supporting our community and our patients with identifying how their social determinants of health and how these inequities are impacting them so we can dive deeper into their goals of care, into their symptom management, and send them back home safely. And as we talk about health equity, I wanted to pass the mic over to colleague Molly. Molly Dollahan is going to share such a powerful situation of health equity, as well as talk through this case extensively, as it's really impacted the patient that we serve here in our community. And I'm sure a situation like this will also sound quite familiar for maybe a patient situation you've encountered along the way.
Thank you so much, Tori. Can everybody hear me okay? Am I using the room mic? Okay. Yeah, you're good. All right.
Yeah,
You're good. Great. Thanks so much. So as Tori mentioned, I'm going to walk us through an actual example that our team had in 2022 here at Corewell. Just to give you a little bit of my background, I've been a social worker here at Corewell since 2007, and I've been a social worker with the palliative care team since 2019. And I met this patient in 2022. If we could flip to this diagram. All right. If you can see this graphic up on your screen, the symbols are of entities here in Michigan that my patient had to navigate. All of the doctor symbols are representing outpatient clinics or outpatient entities, and all of the buildings represent the different health systems that she had to navigate. And the mortar and pestle was 2 different pharmacies. So this all represents just Michigan. We'll be referring back to this frequently. So our patient was a 28-year-old female who was a migrant farm worker. And she'd been in the United States for about 4 to 5 months when she first presented to an emergency room in Georgia. When she was in that ED in Georgia, she had presented because she had a lot of pain in her ankle. And it was felt that it was likely a sprain since her work was so physical. And at the time she presented to that ED in Georgia, she'd been having that pain for 6 months. Eventually her work brought her here to Michigan. And in April of 2022, she presented to the Yellow Hospital System here in Grand Rapids because she was not able to bear any weight on that ankle. Through some labs, they were concerning. She was sent for an MRI, which showed a bony destructive mass in that ankle. She was asked to go to another hospital system, the Orange Hospital System, for an appointment with the orthopedic oncology doctor. So a challenge I'm going to issue to everybody here on the call today is, can anyone tell me how, without using any language at all, nothing in writing, how would you navigate to the ortho-oncology department of another hospital system? Using the information in front of you, you can't use any verbal instructions because those are not in your language. She cannot read, write, or speak any English. How would you navigate to the Orange Hospital System, and specifically the ortho-oncology office? Can't use any language.
Silence is deafening.
Mhm.
Did this person have any support system at all?
That's an excellent question, and that's a great segue because the resource she turned to in this entire situation was, if you see the small yellow doctor, there was an outreach clinic that was strategically located near the migrant farm worker camp. And there was one employee in that clinic that spoke Spanish. It was a nurse, a phone nurse. And so whenever she was given discharge instructions in English, she would find that phone nurse. And that was key, as you'll see in her story. So if we can briefly go to the next slide. When I first got this case, I started flipping through the chart in past notes. And after the mass was discovered, she was referred to this ortho-oncology doctor, but they stated that they wanted her to have a biopsy before she even came to their office. So they tried to call her several times at the number in the chart. And quite a bit of time went by because they couldn't get a hold of her. They were calling and leaving messages, but not hearing back. And they're very concerned because she's got this bony destructive mass. So I was trying to understand some of the delays in presentation, and then came across some of these notes in the chart. And what was happening is they were calling her, but all the options to call back were in English. So she didn't know how to call the office back. And one day, she had reached out. She was getting all these messages in English. She sensed that they were important. She knew she had this mass. But where do I go? What do I do with it? So the phone nurse did 3-way calls to the ortho-onc office that was trying to refer her to the interventional radiology office. We can go back to the previous slide. So you can see there's 2 different departments with outpatient clinics with the Orange system. So the ortho-onc was trying to refer her to the interventional radiology office. She couldn't call them back because she couldn't understand the voicemail messages. The nurse in the yellow migrant clinic put her on a 3-way call with interventional radiology to be able to set up a time to get the biopsy. And that was how that appointment got established. So she went to, had the biopsy done, and discharge instructions were provided in English for how to care for the site. If we can go to the next slide again, what's this case example? So in doing some more digging, I came across a note where she started having profuse bleeding from that site. And she was covering the wound with paper because that was the only resource she had available to her. And wasn't able to read the instructions for care of the site. Again, the phone nurse walked her through that. And the biopsy came back with a diagnosis of clear cell sarcoma. So we could go back to that graphic slide. So questions I found myself asking is, what would she have done if there wasn't this strategically located migrant clinic? What would she have done if she didn't know about this Spanish-speaking nurse? How would she have navigated? So upon getting the diagnosis of clear cell sarcoma, which was a very concerning diagnosis, the Orange ortho-onc office with the Orange Health System referred her to the Purple Hospital, which had a specialized sarcoma clinic, which was 3 hours away from Grand Rapids. Fortunately, in my patient's case, there was another, when she traveled to the US, they came as a group. So one of the members in her work group owned a car. So she didn't have access to that transportation. It was one car for, I think, almost everyone at the camp. But she had to take time away from work to travel 3 hours one way to get to the Purple Health System, which was in another city. So she did make it to that appointment. And another challenge that we came across here is, this was back in 2022, and at that time, not all of the health systems on this screen use the same electronic medical record. And so I didn't have access to all of the notes linking her care through all of these different systems, which was a challenge. So not long after her appointment at the Purple Hospital Clinic, that's the little purple doctor there, she was hospitalized again, or had her first hospitalization at the Orange Hospital System. At that time, she was found to have lung nodules, a worsening cough, and bilateral pleural effusions. She was treated, she was sent back home. And then I would say within 24, 48 hours, she had her second hospitalization. This is in August. And at that second hospitalization, she was found to have mets to the lungs, pleura, lymph nodes, soft tissue, right femur, left tibia, right pneumothorax, bilateral pleural effusions, and innumerable uncountable pulmonary mets. We were consulted around this time to do goals of care for a terminally ill patient. In the course of talking with her, one of the questions she asked us was, where is my chemo medication? And we learned after doing a lot of digging, and again, we have the dilemma of the electronic medical record at the time, and there's still limitations today. I can't see the medical records of all the entities on the screen. And after doing quite a bit of digging, we learned that the Purple Health System sent the prescription for her chemomed to the Green Oncology Office, which is a completely independent entity that does not share the same medical EMR with all the other entities. And it was sitting in their pharmacy for weeks. And any messages that went to her were in English that she couldn't understand. So the clock is ticking right through all of this, all of these delays. She shared with me as I got to know her about her housing situation, and Tori had shared that slide about housing. As a migrant farm worker, your housing is owned by the farmer. And in order to stay in that housing, you have to be working. So if you can't work, you can't be housed. So with her medical condition, some of our conversations were around, as we're getting to know her, she was so ill, like, is there anyone that can help take care of you? Nobody, because if they stop working, we all lose our housing. Not just me, this impacts everybody in my family. It's not just me that would become homeless, they all would become homeless. If you can't work there, you can't stay there. It gets very concrete very quickly. she was not a US citizen, she was here legally on a work visa. She could only qualify for what, Tori had referenced, is ESO Medicaid. E is an Echo, S is in Sierra, O is an Oscar, ESO Medicaid, which covers services in the hospital, but the minute you leave the brick walls of the hospital, it doesn't cover anything outpatient. So no outpatient prescriptions, no outpatient visits to any of the little doctor symbols on the screen. And no DMEs such as oxygen or anything like that. So we're still in August. She made, after, learning all these things, she made the decision to leave on a Tuesday, to just go home to Mexico the following Monday. She wanted to die at home, and she wanted to be near her parents when she died. And that's a goal of so many of our patients, right? To die at home. She was very sharp, very resourceful, and she asked if her records could be translated to take with her so she would have something to give to a doctor when she got there. We reached out to translation and interpretation services, and I learned at that time that they recommended coming up with just a written summary of all of this, because it would take a week to translate 1 to 2 paragraphs. And that is a standard of how long it takes, because it takes a very long time. They couldn't translate all of the records. We were also informed that discharge instructions could not be translated on the day of discharge. Again, because it takes time to do the written translation. When we talk about translation and interpretation services, translation is written, interpretation is oral, and what they do is oral, not written. It's 2 different areas in that department. So one of our docs prepared a 1-paragraph summary of all of this that you're seeing on the screen that she could take with her on the day of discharge. As we were getting closer to discharge, I was very concerned about her having her meds to fly home with, because she was definitely needed morphine to help with shortness of breath, et cetera, et cetera. Knowing all the challenges we were having with translation, I asked the bedside nurse to show me what it would look like for the discharge instructions to be translated, because I was being told that in the software system we had at the time, you just push a button and everything is translated into Spanish. So I said, show me what it looks like. So if we could go to that slide, where's this piece? So next one, yeah. This is what it looks like to get discharge instructions in Spanish in the current EMR. If you can read it, you'll see that the SENA is in English, but the SENA is in Spanish, but the morphine is in English. And this is a known issue. It's still not fully resolved, that is working through, and it's a limitation of the EMR. If you look at the schedule for when you take your morphine, that's in English. So what I learned in this experience is always show me what this is going to look like. And basically what we came up with is that we would have an interpreter in the room at the time of discharge. However, it will be the family's responsibility to write everything in Spanish, which works if everybody is able to read and write in Spanish, which is not always the case. If we could go back to the screen with the graphic, her prescriptions were sent to a pharmacy here at the hospital because she was going to leave on a plane the very next day. So the day she was like discharging on a Friday, or discharging on a Monday, flying out on a Tuesday. Really needed that morphine to be successful in this flight, which was, I think, it was an 8-hour flight. So the day of discharge, the prescription is sent to the pharmacy under the orange hospital there, which is an independent entity of the hospital. It's a completely private, independent entity. And they were out of stock. Her morphine was out of stock. So they just automatically sent it to another pharmacy an hour away that happen to have it in stock. And this is at 8 o'clock at night. So the buses don't go to that other pharmacy. Fortunately, she had access to a car. If she didn't have access to that car, she would not have gotten it. And I don't know if she would have been able to get on the plane and get home, and she would have died. I called the pharmacy to ask if they could please print the medication labels in Spanish, and they do not have the capability to do that. And still today do not. How do you tell the difference between your morphine and your center? So what I asked the nurse to do after they got the medication was to bring it back, and the nurse like color coded the bottles so they could know the difference between what is what. I'll skip through some of the other details, but we had to have a DME company donate an oxygen concentrator because oxygen for, community use would not be covered under emergency Medicaid. None of the prescriptions are covered under emergency Medicaid. The oxygen is not covered under emergency Medicaid. So they donated a refurbished oxygen concentrator, and if we could go to this slide. So again, the EMR printed out this for the discharge instructions. If you are someone that relies on graphics because you can't read, what is concerning about this picture for an oxygen concentrator? What do you notice?
It's not a concentrator.
Exactly. That's what is automatically printed for Spanish discharge instructions, and none of the instructions for the oxygen is in English. So there was many more details I could go into about this situation, but those were the highlights. Even if she had gained citizenship during this time, there is a mandatory 5-year waiting period for Medicaid. So she would be dead by the time she would qualify for that. If she lost her housing, Tori had shared that there can be a wait list of 5 years for housing in the local area. I'm going to see if we could flip back to one of Tori's slides, going back to slide number 7. So in listening to her story, what do you think were some of the biggest barriers, or what were the social determinants of care that you heard in her story? Language. Housing.
Transportation,
Mhm.
financial resources, insurance, just general agency in general.
Mhm. Now, when we looked at that graphic, we can go back to the graphic again. When we looked at that graphic, knowing that you had to navigate 3 different health systems and 5 different outpatient clinics without using any language, how did that feel? What were some of the feelings that came up for you?
Overwhelming.
I think that'd be a challenge for any of us on the call, for ourselves or a loved one, even before we put in the other challenges.
As I heard her story, she taught me so much, and I'll never forget her. And it kind of hit me that, I could know everything there is to know in my social work textbooks on how to treat my patients. But if my patient can't get to my office, it doesn't matter. And it kind of taught me to ask a lot of questions. And one challenge I kind of took on for myself was, I've never ridden the city bus to my own office. I'm gonna try it. And it was very eye-opening on just navigating my own community that I've navigated for years and years and years. And I tried to picture, how do I read, I tried to take the bus to my office without even reading the schedule, because what if I could not read the schedule? So one challenge, you know, if as leaders, if we're not asking people to do things that we aren't willing to do ourselves, try taking the bus to your office. You know, it's very, very eye-opening. And look at the schedule. When does it stop running? You know, when are we asking people to pick up prescriptions or get their oxygen or whatever? And where is it in the community? Another option can be, I know often there's poverty simulations that are given by different organizations in the community. Participating in one of those can be similar to this. That's also another way to really kind of understand the community around us. And her housing situation was unique in that, you know, she had to work in exchange for housing. And if we could look at slide 12 real quickly before I wrap up. You know, in her case, it struck me that we have all these different categories for social determinants of care, but they're not neat and tidy, right? You could say that even though she had Medicaid, she was both uninsured and had Medicaid. She had Medicaid while she was in the hospital, but the minute she left the four walls, she was completely uninsured. So even if you have Medicaid, you can be completely uninsured. Any questions on any of this as I wrap up?
I just a quick comment, Molly. I was just really touched by this, and I think it's really shows the glaring gaps that we have in our systems here. But I was thinking about the farm on which this person worked, and this is probably just more of a rhetorical question, but what are the responsibilities of that owner to take care of his employees? Yes, they provide housing and they provide a salary, but where does the level of humanity and compassion come in to where they would say, yes, she's dying, she can stay here? Or is it that just a strictly business? No, that's not part of the deal, and they have to leave. And the other, I guess the summary question, did she make it back to Mexico?
Thank you so much. Those are excellent questions, Dr. Mulder, and I'm glad you brought that up because in slide 13, there was a statistic here that, you know, 1 in 4 survey respondents face barriers when trying to access healthcare, and that refugees and immigrants, 58% said that they had barriers related to translation services. For this patient, I asked her the question, can you let the farmer know about your situation? She wouldn't. She was terrified. She said, if I do that, we'll lose our housing. It's not worth the risk. And it just became, again, a risk benefit thing of, and I suspect that in that 58% that responded to the survey, it's very, very underreported because there are many people that are afraid to interact with survey tools like this and are simply, she wouldn't tell the farmer. She wasn't willing to take that risk. She did make it back to Mexico.
Thank you.
Any other questions before I hand this to Natasha? All right.
Thank you, Molly.
I have a question. I mean, as I listen to this, it's just, I mean, we've seen patients like this or in situations somewhat, you know, parallel to this, and it's just, heartbreaking is not even the right word, but it, you know, and also to kind of John Mulder's point, this is definitely a societal problem and a societal solution, right? As healthcare workers, we can try to be aware of these issues, but if that employer doesn't allow her to stay, like these are things outside of my control. I love the fact that you had the humility to say, I'm going to try to do the things I'm asking my patient to do just to get that compassion. But there's a limit as to what we can do for our patients because of the way healthcare is set up, because of the way our society is set up. And maybe this is a rhetorical question, but maybe it's not. What is, and for anybody really, what is our responsibility as, you know, we live as community members, you know, looking at how to help policy change, how to advocate for that, how to make things better for our community, the patients that we serve. Nothing a quick fix, but what is our responsibility in this? I really struggle with that. I mean, I love your humility. Definitely, I feel like for myself, I can definitely have more humility in all of us. But then beyond that, what is our responsibility? Sorry, that was not a succinct question.
No, I love that. And it's, I think, so great to be mindful of how can we, I mean, we can't ever fully walk in someone else's shoes, right? How can we embrace that humility, right? To have a humble posture and be curious. I found myself asking the question of, yeah, I think of myself as a helping professional, but if I'm not in tune with these social determinants of care, am I being a hindering professional? I think for me, and I think we've had discussions about this too, another red flag could be if we're seeing in the chart non-compliant, can that be an automatic challenge to look for what social determinants of care are we overlooking? What do I need to learn from my patient? What questions can I ask that are not threatening, but help me to move from being a hindering professional to a helping professional? Yeah, these are all excellent questions.
As say the red flag.
Yeah.
You see that, is it really not?
Can I follow up on the concept of the word non-compliance and red flag, which I agree with 100%. And I'd like to use as an example for those of us who've been practicing for a while in our evolution. And really my statements here are for all of us on the call, especially our younger colleagues. You know, how can we do better going forward, to Simi's question? We wouldn't have had this conversation 20 years ago, right? We would have simply labeled our patient non-compliant. And even on our worst days, then if they're that non-compliant, we might even go on that, well, clearly they have a borderline personality disorder. It's all on them, right? Yep. Simi and I recently shared a patient where I saw that non-compliance was put into the medical record and carried over for a hospice patient. And we had a CEO at our group down at Lakeland who really challenged us on what does non-compliant really mean and why, right? Is this a nefarious thing the patient is doing, or are there barriers to get there? And so, yeah, I'd really like to challenge us with the words we use, how that develops. I could not even, when I saw that, right, it triggered me. It would have triggered me 15, 20 years ago. And I want to get back to the concept then of agency. Think of how much agency everyone on this call has just by having a badge, and then to act to leverage that in every way possible for all of our patients. And when we sense why aren't they complying, to do that deeper dive into the why. Rarely is it they woke up today just to make me angry with that, right? Where don't they have agency? Where can we lean into that? And hopefully 20 years from now, some of the people on the call will be leading this conversation, and it will be better than it is today.
Thank you for that. Yeah. And how can we use our skills around differential diagnoses for social determinants of care?
And to that point too, about kind of 20 years down the line, where do we hope to see medical care as a whole? You know, going back to these kind of societal things, And what does our medical workforce look like? And helping to support people who are underrepresented in medicine. And that starts at the K through 12 level, getting people interested and supporting people in the sciences and in social areas of health, and having programs in local colleges and universities and having outreach for those communities and supporting them with scholarship so they can go to, you know, higher levels of medical training and get them in our workforce. So when we look at our healthcare workforce and how that's distributed, I don't know, I'm trying to find the right word, but like, what's our demographic of the medical workforce, and to have that diversity, because that will be better for our patients and better for the healthcare system overall. But it's such a huge undertaking, and it's at multiple levels. So kind of like knowing what's our area and how can we create that change within our area, and hope that everyone else is also doing that too.
Yeah, and Simi, I appreciate your comment there. How can we do our part to be a part of policy change, even beyond medicine, whenever we can? And my knee-jerk response to that is two ways. Number one, we all work within some element of healthcare systems, and to make sure that we are advancing the conversations with our administrators to say, what are we doing in terms of providing translation services, whether we're a hospice or a hospital? What are we doing to provide the resources to make sure that these transitions go smoother? And quite frankly, I think that probably some of the smaller organizations might be more nimble and able to access more interesting resources than sometimes the larger systems. But what can we, you know, we keep the conversation going. We keep putting it on the table. We let our administrators know this is important and we care about this. And the other thing is just, it may sound trivial, but you know, we got an election coming up. And I think that if we look to the policies of our local, our state, and our national candidates in terms of what are they saying about these issues, and how can we then make sure that if this is a priority for us, personally, I think it should be. Are we allowing then our voices to be heard in the ballot box to support these policies that we think are important?
Or in like national meetings for like our
Sure, national meetings, absolutely.
You know, American Medical Association, or, you know, like my AAPMR, and kind of those advocacy groups, and what is on their list to try and advocate for and lobby for.
Yeah, I'll just for those of you who are not members of our academy, you ought to be. They are doing some really great work in this field to advance the importance of this, and to really institute and forward policies and practices that address these issues. So,
thank you for the comment about representation and diversity. I'm convinced without that one bilingual nurse, her case would have been completely different. I think she would have just died here.
So I know that we're a little over time, but I think this is really important. And did Natasha have some comments to close us out?
I do, and I will be brief. And honestly, I think you all are kind of tracking exactly where I was planning to go. And, you know, I think that people who are consistently given the message that their personal value and their purpose and their place in society is in question, or is less than, or is negligible, or non-existent, you know, those are folks that have to consistently ask spiritual questions, maybe more often than those of us who have more comfortable life circumstances. Because if you're receiving a message all the time that your personal value is minimal at best, probably your heart and soul rebel against that. Because I think as individuals, we know on some level that we do have value and purpose as an individual, and we have a place, and we long to embody that purpose and love and be loved. And those, I think, are essentially spiritual questions. You know, what matters? Why do I matter? What is my value and my purpose in the world? What will be my legacy when I move on from this world? And I think that one of the ways that we can essentially lift up the spiritual health and well-being of our patients is by honoring that in them, by listening to them, by making room for their own voice to be heard. And when we've listened, then to act. As you've all brought up ways that we can act, it is not a process without intimidating aspects, because the issues can seem so big and thorough and vast. But every time you listen to someone and you can promote and enhance their spiritual well-being by demonstrating to them in that one-on-one interaction that they matter, that they're worth your time, they're worth your attention, they are worth doing the work to make it possible for them to have the same opportunity to be well as anyone else, that matters. That matters. It is good work on the tiny scale and on the national scale. So I would just encourage you to hold on to that that capacity, that every little bit counts, and if we all do a little bit, it does add up to a lot, which is the only way that we can make the changes that we want to see.
Thank you, Natasha. And thank you, Molly, and everyone for talking about these things. I just want to end with really reflecting, thinking about how your own healthcare system is committing to improve health equity. What are you doing in your community, or what are you doing every day to help implement these improvements? Joining coalitions, joining different alliances in the community, writing letters to our policy members who are in legislation that can make these changes. You know, our voices matter. And I think sometimes in our large systems, we forget that. Our large systems at home, our large systems in the community, or even the healthcare teams, that you are important and the things that you see are important to capture. And then what can we do as team members to impact and make changes in our system? Just as Dr. Mulder shared, taking this to our leaders, to take this to the different committees and boards they're a part of. We have to start speaking up on things we see so we can continue to improve the work we do every day. Conclusion, just the root cause of these inequities began historically in contemporary inequities that have shaped by institutional and society structures, policies, and norms in the United States. There are so many layers of health equity that we didn't even get to touch on. This topic could take probably years to discuss and unpack the layers that have happened and shaped and molded the society we're in now. But we can do better today. We can do our part, taking a pause to know your patient's story, to change the language in the chart, avoiding the frequent flyer, avoiding the non-compliance, naming the things that our patients are facing and sharing their stories, taking your personal stories to your team and the community, advocating for those that don't have a voice, and asking our system and community and leaders that we choose to vote for to help correct these changes, help correct these situations, and to update the policies in place. I appreciate everyone's time today in talking about health equity. Again, this is work that is very hard and things that we do every day. But if we all are allies to one another, we can continue to do this work and we can continue to do it well. I thank Molly and Natasha for joining today. And I thank you all for your great questions and really reflecting and take away on what you can do better today to capture that story and to impact that patient's life just a little bit better.
Well, thank you, Tori and Molly and Natasha. What a really relevant and a great presentation. A lot of food for thought, and thank you for doing this again.